going to be doing today is what we are going to be discussing is drugs options that are available for vestibular migraine. In fact, migraine as such, so that it also applies to vestibular migraine too. And with me, I have Dr. Sushma Sharma, who's an MBBS, MD, DM, and a DNB, okay, the neurologist, and we've been talking to her, interacting to her for a long time, for many years now. Whenever we have some doubt, we go to her, okay, and she's very kind, very approachable, and she does explain like what is right and what is the tips and tricks and all these things. Okay, she's been Asian Epilepsy Academy certified electroencephalographer, certified in assessment and management of vestibular disorders through multiple certification programs. She's a director of neurology at Metro Hospital, Faridabad. What is written here on the slide is very little about her, that her areas of interest is epilepsy, vestibular neurology, and neuroimmunology. She has book chapters published. She has publications in national and international journals. She is a member of the American Academy of Neurology, Indian Academy of Neurology, Indian Stroke Association, Indian Epilepsy Society, and the recipient of the Women Achievers Award 2017. In addition, there is more to her. She has multiple other interests. She's an orator. She has interest in other literary fields. She's also a rank holder throughout. Okay, she's a rank holder throughout. In her 10th, she stood 9th in her state. In her 12th, she stood first in her state. So like that. So now today, what we are going to be interacting with is an achiever from her childhood. Okay, and throughout. So welcome, ma'am. Welcome to this session. Okay, and so the way the usual today is the 12th grand rounds. So we crossed an year of being on the grand rounds, and thank you all of you for joining in and being a part of this family. Okay, so. As we go on, in fact, I do encourage, this more like a small group discussion. I do encourage, if somebody wants to interrupt, ask a question, you can always raise your hand, and then we can take questions in between also. 1 hour of very good interactive session is what we are planning. Is that okay? So fine. With that introduction of the Dr. Sushma Sharma, the way I'm planning this is we take one drug after the other, and take madam's opinion as to when she will be using it, what are the tips, okay, what are the precautions to be followed, in which age groups, which drug is good, like that. So I'll start sharing that. Please let me know if you're able to see the slides. Let me know if you're able to see my slides.
Able to see. Yes, able to see.
Yeah, in any case, I will reshare. Okay, so we are able to see it. Excellent. Okay. Yeah. So vestibular migraine, drug options, how they work, and how to use. Okay, this is the topic of the discussion today. So most of the I have referenced to to form as a basis for this discussion, reference to 3 articles from Neurotherapeutics that was published in 2018. One on current prophylactic medications for migraine and their potential mechanism of action. There is one more which is a non-pharmacological or therapy for migraine, and one more specific article on calcitonin gene-related peptide and their role in the management of in the pathogenesis and management of migraine. So with these 3 things in mind, we will proceed from one after the other, from the traditional medicines to the newer generation things that are available, the non-pharmacological tools, and as well as when I tell non-pharmacological, I'm not talking about lifestyle, I'm actually talking about other devices. And then we are also going to talk about the game changer, the present, probably a game changer, that is going to be the calcitonin gene-related, peptide-related things. Okay. So the first class of drugs let us discuss is beta blocker, okay, which has been there for a long time. Propranolol and metoprolol. Propranolol is usually suggested in a dose of 40 to 120 milligrams BD, Metoprolol 25 to 100 milligrams twice a day. Now, how do these two things work? There are multiple ways in which they are proposed to work. One is inhibition of nitric oxide synthase, interaction with the serotonergic system. Specifically for this, okay, I used to keep looking for drugs which act as a thalamic level, and the beta blocker is seen to be one drug which actually has an inhibitory action on the thalamic relay neurons, and then the block of the central sensitization to nociceptive stimuli. These multiple mechanisms of action help in the action of the beta blocker. Not every beta blocker is same. There are some beta blockers which work for migraine. Not everything works for migraine. So this is especially the ones that are that have other action on alpha adrenergic. They don't really have an action on migraine. Now I want to bring in Dr. Sushma. Ma'am.
Yes.
Beta blockers. What is the good of it? What is the bad of it?
So with beta blockers, these are, in migraine prophylaxis, we usually use, like, there are first line drugs and there are second line drugs. So whenever a de novo new patient comes, so among our first choice drugs, the first line drugs, we use flunarizine, amitriptyline, and beta blockers. These are usually the first line drugs, the first choice drugs. Why? Because there is a lot of safety aspect associated with it. Beta blockers are good. First, the good of it, one, they are effective in migraine. Second, especially in throbbing, component of headache, they work very well. Thirdly, they decrease the anxiety component, which many a times is associated with migraine. So by decreasing palpitations, by decreasing the resting heart rate, if we find that the patient is otherwise of an anxious nature, beta blockers would be our, they would has a throbbing kind of headache and is anxious personality. Beta blockers would come in our, among our first choice of drugs. They are non-sedating. They do not sedate the patient. They can be used during the daytime. So these are the advantages of beta blockers. And among the disadvantages, they decrease the heart rate. So one has to be cautious about heart rate. And we have seen patients coming with heart blocks which were only induced due to the beta blocker use. One has to be very cautious while using propranolol. Propranolol is usually what most of the neurologists in India use. Metoprolol, usually we do not use primarily for migraine. If the patient already is using metoprolol, say, for some cardiac condition, then we, that might also help in migraine. But primarily when we start beta blocker for migraine per se, we are using propranolol, most of us. And though the dose can go as high as 240, but it is prudent to start with a 40 mg dose. We start with 40 mg dose and we check for the response. If there is no response or less response at 40, and if the heart rate of the patient permits, if the heart rate is remaining at least 68 to 70 or more than that, minimum 68, we might increase to 80. Going beyond 80, one has to be very cautious and advise the patient that patient should keep checking the resting heart rate. If the resting heart rate goes less than 55, we should alter the dose or we should switch over from beta blocker to some other drug. So another thing is asthma. If the patient has bronchial asthma or asthmatic tendency, asthmatic bronchitis, we cannot use beta blockers in such patients. They will aggravate the asthma component. So in COPD, we are in bronchial asthma, we don't use. In COPD, without asthma, we are cautious because they can still cause bronchospasm. So that is the disadvantage of beta blockers. Nevertheless, they remain one of the first line drugs for the routine prophylaxis of migraine patients.
Yes, ma'am. So as just to summarize once again, what Madam told is among the first line drugs which she considers for migraine, flunarizine, beta blocker, that is propranolol, and amitriptyline are the three drugs which are the first line drugs for migraine. And when it comes to beta blockers, 40 mg is what Madam suggests that we should start off. Maximum you can go to 80 in Indian patients, not more than that. And that also with monitoring of the heart rate, because bradycardia can happen with this thing. So two things to monitor. One is whether there is a bradycardia. Second one, or any heart block developing. And the second thing that we need to be looking for in this particular group of patients is that we need to take a history and be sure that they don't have a reactive airway disease like bronchial asthma, COPD, and any of these things which can be exacerbated. Ma'am, one more question when it comes to beta blocker. What age group and is okay? Like, is it advisable in the very young? Is it advisable in the elderly?
What did you say? Is it advisable in the very young?
What age group? Yeah.
Or in the elderly?
What is the youngest person to whom we can start? We can think of beta blocker, which is the oldest person to whom we can think of a beta blocker.
In older people, we should be cautious because older people usually have cardiac comorbidities and they have conduction defects already setting in. So the conduction blocks can get aggravated and heart blocks. As I said, that we have seen patients in whom heart block got precipitated because of propranolol. So these are usually patients who are elderly, like more than 60 years of age. They have already underlying sinus nodal dysfunction, starting to come up, and then in some of them, and then that can get unmasked by the use of propranolol. So in elderly, we would not usually, we would be very cautious. It's not that we cannot use. Certainly we can use, but we have to be cautious while using propranolol in elderly. In very young children, usually flunarizine is our first choice rather than propranolol. But propranolol is also an acceptable drug even for younger age group, even for pediatric age groups. I would say more than 10 years we can give it. Not that we cannot. It cannot be. We should not be using it in pregnant females though. Beta blockers are, they are not. They have a warning for pregnancy. So we usually avoid using them during pregnancy. So in extreme, like just to sum up, in elderly, we are not very comfortable. In very young children, flunarizine is a better choice than beta blockers. From teenage onwards, we can certainly use beta blockers. And among young people, we try to avoid them in pregnant females. Other than that, we can use them.
So avoid in pregnant women. Otherwise, you can give it even in younger kids. Even in older people, it is allowed, but with precaution because it can precipitate a disease. And one more thing about beta blocker that, and Dr. Avinash Bijlani is asking, what is the dose in the pediatric group? If at all you give, at what dose do we start? Like for the 10-year-old child, if at all we want to start a beta blocker, what dose would you start?
I would start with a 20 milligram dose. But I would monitor the child, and after 2 weeks, if I feel the if the child is doing if I feel the need to, I will go up to 40 milligram. After 2 weeks,
you can go up to 40.
Weeks, up to 40. I would not use 80 in a child. I would not use 80.
Okay, ma'am. So you would always begin with 20, but then you can proceed up to 40.
And
that's to after 2 to 3 weeks.
In adults, I will begin with 40.
In adults, the starting dose is always 40. Okay.
Yes.
Excellent. One more question, ma'am, about beta blocker. One study shows in beta the way the beta blocker action is that the central sensitivity to sensory stimuli itself is low. And to prove that, there is a study that where they do VEPs, visually evoked potentials, and they say that that response is attenuated. The response is lesser after treating with beta blockers. So can we, is somebody doing that kind of a thing to see the effectiveness, whether the person is actually responding, or that is more like a study purpose and nobody really does that?
No, we are not using, clinically, we are not using BP to check for, though it sounds very interesting. I'm hearing from you only. It sounds very interesting and it makes sense because we are using the migraine prophylactic drugs. The idea is basically, migraine is basically a peripheral, it is basically a central hypersensitization disorder only.
Yeah.
If the brain becomes less sensitive to the light stimulus, if the photosensitivity becomes less, then if the photophobia becomes less, then it is understandable that the peak amplitude of P100 in VEP might become lesser. So before and after beta blocker, it sounds very interesting. Clinically, we are doing VEP regularly for many conditions, pathological conditions. But to check the effectiveness of drug in migraine is not one of them. No.
Okay, ma'am. Sure. So we do use it regularly, but not for this. It has not become.
No, we use it for.
It has not come to the clinic. Yes.
For optic neuritis, basically we use optic
Yes,
neuritis,
ma'am, for optic
or
neuritis.
for other traumatic optic neuropathies. For those we use.
Yes, ma'am.
Not for
Those you are using. Okay. Do you recommend routine cardiac evaluation before beta blockers or not required?
No, not as a routine. Only if I suspect. Only if I'm
Only if you,
suspecting.
yeah.
Yes.
Okay. Okay. So now Dr. Neha's question was that. I think that is also answered. Okay. Coming to anticonvulsant. In fact, this is one place where everybody is waiting for your answer and opinion. Okay. Okay. There are two drugs which anticonvulsants which are used for the management of migraine. Okay, one is valproate, another is topiramate. Valproate 400 to 600 milligrams twice daily, recommended dose. Topiramate 50 to 200 milligrams per day. Now, the mechanism of action of these things is like when it comes to valproate, it's a voltage-dependent sodium channel blocker, blockage of low threshold T-type calcium ion channels, suppression of protein kinase C, glutaminergic neurotransmission. And glutaminergic, these things make sense. I'll just try to explain for this thing. Okay, one is sodium channels, the other is calcium channels. When we look at the neuronal function, or when we look at the function of a cell itself, there are ionic fluxes happening all the time, which means there are some ions moving outside, there are some ions entering inside. And there is also a homeostasis of a certain concentration maintained, in the sense some ions are richer inside the cell, some ions are richer outside the cell, which is there for the neuron too, for everything else. And to make, see, first and foremost point that we are making is, for normal functioning of the cell, including the neuron, there are some ions which are normally more rich inside, some ions which are more rich outside, sodium, potassium, calcium, whatever. That is the point number one. Point number two is maintaining this concentration gradient or difference between the two sides is an energy dependent process, which means the body needs to actually spend energy on certain pumps to make sure that this particular ionic concentration is maintained. So it's an energy dependent process. Now, if at all somebody has bad channels, there is a possibility that those channels are leaky, or more excitable than usual, or less excitable than usual, or episodically more excitable, or episodically less excitable. These are the different kinds of problems that channels can have. These are all called as different kinds of channelopathies. When somebody does not have a good enough channel, it can be said that possibly a person who doesn't have a problem with these channels spends less energy to maintain that concentration gradient, to make sure that the ions are in the right places, less energy, whereas a person who has defective channels will need to end up spending all the time, most of the time, more energy than usual to maintain that gradient. So these ion channel blocking agents, to some extent, somehow convince in helping the body to probably maintain that homeostasis, is one way of looking at it. So that is why this is not just one line. When we say blockage of voltage dependent sodium channel, blockage of voltage dependent sodium channel is helping the body in probably maintaining the ionic balance between the two sides. Then blockage of low threshold T-type calcium ion channels, again, that is similar. Then suppression of protein kinase C, which is a glutaminergic neurotransmission. When it comes to, again, there is a glutamate and there is a GABA. GABA is the inhibitory neurotransmitter, which enhancement of which is known to help in bringing down pain, bringing down overall hypersensitivity thing. Whereas glutamate is an excitatory neurotransmitter. So these two things, most of the things that work on migraine actually suppress the glutamate, and probably in some of them enhance the GABA. Then inhibition of the NF-kappa B pathway in animal. This is the down regulation of CGRP. We have a separate section on CGRP. We'll come to that later. So both of them are similar. Okay. So, and then when it comes to topiramate as an epileptic is considered a dirty drug because it acts on so many channels. And it seems that because it is a dirty drug in epilepsy, it has become a good drug when it comes to migraine prophylaxis. Blockage of voltage dependent sodium channels and high voltage activated L-type calcium channels. Glutamate mediated excitatory neurotransmission is again inhibited. facilitation of GABA, so mediated inhibition. So this is what glutamate is an excitatory neurotransmitter, GABA is an inhibitory neurotransmitter. So these things facilitate the inhibition and suppress the excitation. And the inhibition of carbonic anhydrase activity is one more very nice effect of topiramate. That is why even in marginal idiopathic intracranial hypertension also this is also being considered. Reduction of CGRP secretion from the trigeminal neuron. We have another section on CGRP. We'll come to that. So as of now. Now I want to bring in Dr. Sushma now again. Ma'am, when it comes to...
Sir, just a second. I'll put on my charger. Just a second.
Sure, ma'am. Sure.
Yes, sir. Yes, sir.
Yes, ma'am. So when it comes to topiramate, we don't have much of a hesitation, especially the ENT crowd here, all of us. When it comes to valproate, we somehow want to hold back because we think we have been taught in pharmacology that it is a anti-epileptic and anti-epileptic. To even think of it in a migraine patient, we have a huge threshold. There is a drawback. There is something that is pulling us down. How justified is it? If at all we have to start off, we want to think of in whom we should start thinking of it as a first patient. If you want to give that prescription, who is that ideal patient and what precautions?
Sir, I'm very surprised to know that ENT people, I didn't know this, that you are more comfortable in prescribing topiramate than valproate, because it is the reverse with neurologists. It is the reverse. Actually, at least in India, we are topiramate, we are not very, though topiramate is a very first line drug and it is not a first line for us, though topiramate is a very well studied drug and is considered one of the most effective anti-migraine prophylactic drugs, but with its list of adverse effects, we are actually wary of starting topiramate, and I'll be much more comfortable in starting valproate simply because I'm much more familiar with valproate. It is much more used in neurology. I know it in and out. I can manage its adverse effects. I can anticipate its adverse effects, and I can identify its adverse effects. Not the case with topiramate, because we are not using topiramate very often in epilepsy. Whereas valproate we are using very often in epilepsy, so a familiar drug. You know it like the back of your hand. Coming to your question as to which patient, I'll again go back to what I said previously, that for migraine prophylaxis, among the first line drugs, the safe options, we consider amitriptyline, beta blockers, and flunarizine. Now, if the patient is not responding to these or to a combination of these, then among the second, so one step up with the better efficacy, but with slight risk of toxicity, we go to valproate or topiramate. These two then come in that group. They are more efficacious, but they also are more toxic than the first line. First line we can give it usually with closed eyes, don't have to think much. Now valproate, where to give valproate? We avoid it in women of childbearing age group. That is where we do not want to use valproate. In others, valproate can be used right from childhood to old age. It can be used. For males, there is usually not much of a thought when we are prescribing valproate. We usually, instead of prescribing sodium valproate 400 to 600 twice daily, this is usually the dose that we use in epilepsy. For migraine, we usually prefer to give divalproate sodium single dose, and it would be anywhere from 500 to 750. That is the usual dose that we give for migraine. Now, which are the people where we prefer to use it? As I said, one is males, any age group. Avoid post-menopausal females, it can be used. If a patient has concomitant, epilepsy, if a patient has epilepsy as well as migraine, then instead of choosing carbamazepine or other drug, I might choose, I would prefer to choose valproate because it will cover both the things.
Wonderful, yeah.
So there, that's how we proceed actually with valproate, and usually we use divalproate. Or if a patient has a mood issue, say bipolar personality patient, so there it will act as a mood stabilizer as well as it will take care of migraine. So one drug to two things. So we use again divalproate sodium. Usually we use rather than using sodium valproate. And rather than using BD dose, in migraine, we use OD dose. It works quite well. So this is about where to use. I think other questions will follow, so I'll keep it.
Yes, ma'am. There are already questions.
There'll be many questions from
Are there any cognitive side effects of topiramate that you have noticed?
Yes, certainly yes. A big yes to it. Yes, topiramate has its own set of problems. One is the cognitive adverse effects. Other is, which we are more, concerned about, is the narrow angle glaucoma precipitation. Whenever I write a prescription of topiramate, we always write along the side of it that watch for any eye signs, or eye signs have been explained, or keep a vigil for eye, everything explained. So we do explain to the patient that it can precipitate narrow angle glaucoma. And we do tell the patients that if the eye were to become red, or if the eye were to become swollen, or if you feel pain in your eye, or if you see visual halos, which are the features of glaucoma, any redness, pain, or visual halos in eye, while you're on this drug, before going to ophthalmologist, stop this drug and meet us. So that is one thing that we tell to all patients whom we start on topiramate. And not only narrow angle glaucoma, I have a case report of my patient who developed an open angle glaucoma without raised intraocular pressure due to topiramate, which then reverts to when we stop the topiramate. So it can even precipitate an open angle glaucoma also, though that is very, very rare, and that is limited to case reports. That is one thing which we always write. We do not write for cognitive adverse effects, but we keep a watch for it. And it can certainly affect cognition. Higher mental functions get blunted if the patient is of a very high intellect level, has to depend upon his intellect for his work, like a judge, a lawyer, a doctor, or a person who has to make split-second decisions, like a pilot, or responsible positions. There I am wary of using topiramate in those patients, because they will come back with its cognitive adverse effects. For a general laborer, farmer, housewife, they may not even notice that they have adverse effects with topiramate. So if your work profile is not cognitively very demanding, then you may not notice that topiramate is causing some cognitive adverse effects. But when you have to use your intellect, there it interferes with the higher level thinking. There it does interfere. Thirdly, it can precipitate, you have to ask the patient to take lots of water when he's on topiramate, at least 1.5 liter water every day, because it can, it has some association with the renal stone formation also. So these things we keep a watch on when we ask the patient to be on topiramate.
So one more. So the point here, what the main thing Madam told is, there as a neurologist, she's more comfortable with the divalproate than topiramate. Okay. One thing about topiramate, some of my patients who are very happy, the happy people are the people who have lost weight with topiramate.
Yes, that is on. In fact, once I had a doctor's wife who came to me and who was demanding topiramate, and I said that are you aware that you have to keep a vigilant eye and all? I can give you a much safer drug like amitriptyline or the flunarizine. So why do you want to start with topiramate? He said, I want to lose weight. So, but it is not a weight loss drug. But yes, it can suppress appetite. It suppresses appetite and it causes weight loss. It can cause weight loss. That is, whereas with valproate it is opposite. You have to keep a watch for weight gain. It really causes weight gain. You have to keep a watch for tremors of the hands. It can cause tremorlessness in the hands, and then you have to give a beta blocker to suppress those tremors. So that is with valproate, and it can cause hair loss, and it can cause a bad hair loss with valproate. So
okay. So hair loss is one thing. Unless you want to, you want to have a hairstyle without hair, then that is one more thing that we need to worry about when it comes to.
Sir, even in epilepsy, sometimes people are, though we think that this is a very small price to pay for, for getting rid of if your epilepsy is getting controlled, then hair loss is a very small price to pay. But that is the way we look at it. For people, their appearance is very important. And it is, sometimes they ask us to change. And sometimes I have to change from valproate to levetiracetam just because person says, ki mujhe to bahut hair loss ho raha hai, I am not going to take this drug. So,
Okay.
So yes.
I think that has answered Dr. Krupa's question also. She wanted to know some of the side effects of sodium valproate. So that is also one more point. With
Thank you, ma'am.
Sir, one second. I am not done with the side effects of valproate. So there are some more.
Okay.
Valproate can cause hyperammonemia and hyperammonemic encephalopathy. So if we find that the patient is becoming dull or encephalopathic, then we do ammonia level, and if they're high, then we might have to stop valproate. It can cause hepatic dysfunction. So one has to keep a watch, both idiosyncratic as well as dose dependent. So one has to keep a watch on liver function tests while the patient is on valproate. And it can cause pancreatitis. Valproate can precipitate pancreatitis. So that is another thing. And it can even cause a non-hyperammonemic valproate-induced encephalopathy. So even in the absence of hyperammonemia, if we don't find any other reason and patient is on valproate, then we stop valproate, and we do an EEG to see whether there is actually a brainwave slowing, and if it is there, and even if ammonia is not raised, we stop valproate. Then it can also induce cytopenias, pancytopenias valproate can cause. So while I'm talking to you, I'm realizing how many adverse effects it has, but we are very comfortable with it because we can recognize and anticipate and stop them. With topiramate, the list appears low, but it is not a very commonly used drug otherwise, so still wary of using.
Okay. Why divalproex over valproate is the question?
Because OD dosage and works equally well in migraine. In epilepsy, it doesn't. Divalproex is inferior to sodium valproate, but in migraine and mood disorders, divalproex is equivalent to sodium valproate, and since it can be given OD, so we prefer it.
Absolutely. Excellent. So coming to the next class of drugs, we have a huge number. I don't know whether we'll be really able to finish by 9:30. I don't think. So if somebody has told at home that you're going to join them at 9:30, please tell them 10 o'clock or something, because we have a lot of more drugs to discuss. Antidepressants. So the two antidepressants which are used in migraine prophylaxis is amitriptyline and fluoxetine. So when it comes to amitriptyline, the dosage the typical dosage to start off with is 10 mg. To say that it is not working, we should really at least go to 25 mg. Before that, don't tell your amitriptyline has not worked. In fact, we've had patients who were having not so good response, but the moment it was increased, the 10 mg dose was made twice a day. There is a salutary effect. They are really, really benefited. So like that, unless you have tried the real dose, then fluoxetine is again 20 milligrams daily. The mechanism of action of amitriptyline is multiple. Okay, it has so many things. Okay, one is of course that usually recognized the action used to be serotonergic, serotonin noradrenaline reuptake pump inhibition, which means there is more available serotonin, more available norepinephrine in the patient's brain, which means the person actually starts feeling more happy. But the happy person also has less sensitivity to nociceptive stimuli. Okay. So that also makes sure that there are the endogenous pain control mechanism, the top-down mechanism, which will which will inhibit the pain is more. Okay, that is the reason why amitriptyline is also works well even in certain kinds of neuropathy. Okay, when it comes to fluoxetine, it's a direct blocker of serotonin reuptake. Okay, it's also reversible 5-hydroxytryptamine into the receptor blocker. So these are the mechanisms of action of these drugs. In addition, amitriptyline also has been known to have an action on the sodium channel. So we know that sodium channel blockage also is going to have a role in the migraine prophylaxis. So multiple ways in which amitriptyline, in fact, there are so many proposed mechanisms, 4 or 5 different mechanisms are proposed for amitriptyline's method of action. And as Dr. Sushma in the beginning only told, this comes under the first line of drugs which he thinks of: beta blockers, the amitriptyline, and the flunarizine when it comes to management of vestibular migraine. So these come under the first 3 drugs. So I would want to take Madam's comments on which is the one, how frequently she uses. In fact, I wanted to ask how frequently you use fluoxetine as a migraine prophylaxis.
I do not usually use fluoxetine as migraine prophylaxis. Apart from amitriptyline, the other antidepressant that we use, that I use as a migraine prophylaxis, is actually venlafaxine.
Okay,
Venlafaxine,
venlafaxine.
yes, that I use as a migraine prophylaxis. Like
At what dose?
desvenlafaxine as well as venlafaxine. Desvenlafaxine, I start with 50 mg OD and go up to 50 mg BD. And venlafaxine, I start with 75 milligram OD and I go up to 75 milligram BD. So that I am using, and we have found it effective also. Fluoxetine I'm not using for migraine prophylaxis. Amitriptyline is actually among the first line, my first choices, among my first three choices. Among them also the first of first is amitriptyline. Apart from in children, I give flunarizine, and in all others, I would want to give amitriptyline unless there is a specific reason why I can't give them amitriptyline. Otherwise, like it is very safe. Only problem that it can cause a bit of sleepiness in the initial week 10 days or so, and it can cause little bit of dryness of mouth. Apart from that, there is nothing internally happening which I need to be, I don't have to monitor liver function test. I don't have to monitor kidney function test. I don't have to bother about heart rate. I don't have to bother with extrapyramidal adverse effects which can happen with flunarizine. So amitriptyline is actually the safest. Whatever little adverse effect it has are time dependent and short lasting, usually gone within two weeks if the patient is compliant, and it is really effective. It is an effective, though it is simple drug, small dose, but it is an effective drug. Patients are usually happy because it also actually causing increased sleep. For many patients, it is actually a positive, beneficial effect rather than an adverse effect when they are actually suffering from migraine, and usually it has an antidepressant action also. So although the antidepressant action doesn't start at 10 milligram and doesn't start at 25, it starts at a minimum of 50 milligram. But still, I mean, no harm if the patient gets a little bit of extra serotonin. So
Yeah. They do start feeling happy at least at 10 mg. There are people who come and tell, I feel happy when I am taking this.
Yes, and they like
may not
this.
Be exact. Yeah. Yes. And one more very good point which Madam told is like the drowsiness is actually short lasting. Within 2 weeks it will settle. So that is a good thing about amitriptyline. Ma'am, one more question is there. Between nortriptyline and amitriptyline, any preference or any reasons to prefer one over the other?
For migraine prophylaxis in particular, I usually give amitriptyline. But if my patient also suppose has a neuropathy, and for that, if I'm using a combination drug like gabapentin with nortriptyline, then I would give that only, and I'll not give amitriptyline. I'll let it work in place of amitriptyline. I am not aware whether there is some difference between nortriptyline and amitriptyline specifically with respect to migraine. I'm not exactly aware of it, but I am using nortriptyline sometimes in place of amitriptyline only if the patient happens to need a nortriptyline, if it is available in combination, and I am planning to use that drug for neuropathy, then I would let that work for migraine also.
Yes, ma'am. So if a combination is required, most combinations are available with nortriptyline, and that is the reason why you would be choosing a nortriptyline.
Yes.
How much time does it take for the action to start for this for the amitriptyline to start showing the migraine prophylactic action? How long should we wait? 1 month, 2 weeks, 3 weeks?
See, for all migraine prophylactic drugs, we usually once we start, we go month by month basis. We start the drug and ask the patient to keep a migraine diary for 4 weeks and record how many episodes they have, and then compare it with what they were having previously and come back to us. So if in the first month I'm talking of headaches, in the first month the frequency of headaches is remaining less than 7, I am okay with it, and in the next month I would want it to get down, get better from there, like from 7, if let us say it becomes 5, the next month it becomes 3, then by the end of 3-4 months, if I come down to less than 3 per month, which are easily controlled with a small dose of the SOS, the need-based drug like neprosin, etc., the abortive agent, not the prophylactic, but the abortive agent, then I'm comfortable in keeping our goal is to bring down the migraine headache attacks to less than 3 in a month, and to maintain it there and to better it from there if possible. That is for headache part. So I think we can extrapolate the same to vestibular migraine also. If the patient at the end of first month, we just want the patient to say that I am feeling better than before, And then from there, we start comparing. We try to have some kind of a quantitative or semi-quantitative estimation of whether the frequency and intensity, both of them are reducing or not. It will be too early to give up on amitriptyline before trying it for at least 6 weeks. So 4 weeks is usually when we ask the patient to come back, and 6 weeks is before giving up on the drug. That no, this is not going to work.
Yeah, never give up before 6 weeks. Okay, and venlafaxine, is it likely to produce earlier benefit? Is a question.
Venlafaxine, actually, sir, I am using where patient is also depressed, clinically depressed, and I need to use an antidepressant, and patient also has a migraine. That is where I am using venlafaxine. So for obvious reasons, it works better there. Yeah. Not for a migraine patient, no. But if the patient, because amitriptyline, the dose is not actually an antidepressant dose, whereas for venlafaxine, it is an antidepressant dose. So, so I let the same drug work for both, and there, for obvious reasons, it works well.
Excellent. Ma'am, one more question is there, but that will come after this slide. That question itself is whether we can use a combination of flunarizine and amitriptyline in the same patient. We'll take that question after we finish this slide. Okay. So calcium channel blockers. Within this, we should also include cynarizine, because cynarizine is not generally thought of. Okay, this is not thought. Okay, not thought of and thought of as a calcium channel blocker, but actually it's a very effective calcium channel blocker, cynarizine. And the most commonly used calcium channel blocker is flunarizine when it comes to migraine. Okay, 5 to 15 milligrams per day is the usual dose at which it is given, but most of us are at 5 and 10. Here again, in addition to the calcium channel, they also block the voltage-gated sodium channels, reduction of neuronal excitability and normalization of cortical hyperexcitability. It also has some amount of D2 antagonism, that is dopamine 2 antagonism. These are the things. And when it, as Madam told in the beginning, her 3 drugs, one is propranolol, another is amitriptyline. In fact, amitriptyline, there is reason not to choose amitriptyline. Other than that, amitriptyline is the first choice. And then the third drug is flunarizine, especially in a child, flunarizine is the drug choice. Ma'am, how do you use flunarizine? In the sense, do you use continuously for a long time, or do you use it in pulses? How do you use flunarizine? Do you give for a few months and then stop it? Or do you combine with other medications? How often do you combine with propranolol? How often do you combine it with amitriptyline?
So flunarizine, it is one of commonly used drugs in migraine, and once it is for all the migraine drugs, the principle that I follow and most of us follow is that, as I said, our goal is to bring down the headache frequency to less than 3 in a month and maintain it there. Suppose I achieve this goal I intend to achieve this goal between 3 to 6 months. So if I have achieved that goal, say in 5 months in a patient, then I wait for another 2 to 3 months to let it consolidate. And once for continuously for 3-4 months, the patient is hardly using a abortive agent, and he's using just once in a month, then that is the point where we slowly taper and stop the drug. So in most of the patients, it will be around 8 to 10 months. In some patients, it will be 1 to 1.5. In some patients, it will be 1 to 1.5 years also. And in some other patients, we might be using combination that it might continue continuously also. So once we stop, it is like, I always tell my patients that it is like charging your phone. So once your battery is depleted, I charge your phone. And then I also explain to you how to use your mobile in a way so that you don't deplete the battery very soon again. So you don't use too much of brightness and all that. So just like that with migraine also, it is just like charging, bringing your neurotransmitters in a particular state so that your brain becomes less sensitive. And then to adopt the lifestyle measures to prolong the effect of these drugs as far as possible so that you don't have to again need the course very soon. Having said that, every person's phone is different, every person's battery is different, every person's lifestyle requirements are different. And just like that, this applies to migraine also. So even though I might have fulfilled your charge at this point and we are stopping your drug, but the effect may last. You may remain without drugs for 1 year, you may remain without drugs for 5 years. We don't know. But at some point of time, you may need to start the course again. As of now, your battery is full and there is no point in charging a phone which is 100%. charged. So I'm just stopping it. If and when we ever need it again, whenever you feel that your headaches are now again more than 3 a month, come back, we will start the drug again. That's how we use migraine drugs.
So this is a very nice analogy, like charging the phone and then waiting for it to get discharged, but then make sure that it doesn't get discharged so soon with lifestyle changes. Okay, so and then usually it is around a few months, like 10 months, something like that, or it can be 1.5 years. In some people, it can be very few months also.
Yes.
So there are two questions here. Okay, Dr. Charwas is asking, why not escitalopram as an antidepressant in this migraine patient? The entire today, what we are discussing, just to reiterate, it may look like we are all discussing only headache. There is a lot of understanding now among vestibular professionals also that is emerging, that the drug therapy for vestibular migraine and the drug therapy for migraine is almost similar. There is one disease with one subgroup of the disease, and therefore the approach of drug therapy should be similar to the migraine approach. Okay, though it is vestibular migraine. With that, we are proceeding. That is why most of the drugs that we are discussing is actually migraine drugs, but they are equally effective even in vestibular migraine. Why not escitalopram is the question, ma'am.
Escitalopram is not well studied in migraine. It is a very good antidepressant. Okay. If I have to use only an antidepressant, escitalopram is my first choice. But if I have to tackle both the things in the same patient who is having migraine as well as depression, there venlafaxine is my first choice, because venlafaxine, there are many papers on effectiveness of venlafaxine in migraine.
Okay, ma'am. And one more thing is, dose, when you start in a child flunarizine, what is the dose at which you start?
I usually start with 5 milligram dose in a child, and depending
on less than 10 years.
So less than 50 kg, I start 5 milligram dose. More than 50 kg, I would start with 5, but quickly escalate it to 10.
Okay.
For so child, for adult, I will start with 10 milligram dose.
Yes, ma'am. Okay. Now coming to that other question, which Dr. Anju is asking, flunarizine and amitriptyline, can we prescribe it together?
I haven't used this combination much, though I have seen
you are not used it,
but I have seen some of my colleagues use it. And I think considering that they are acting through slightly different pathways, so it is okay. It's not that they cannot be, but somehow the combinations are not available. Flunarizine with beta blocker is much more commonly available even in combinations. Yes, so that is much more commonly being used.
Okay. So, but then you have seen other people using it.
Yes, I have seen. Yes. Sometimes when we have to use 3, suppose I have already given flunarizine and beta blocker and still patient not controlled, then I might add amitriptyline. I have done that. Yes, sir.
Okay.
So one point about just flunarizine, if you allow me, the last thing was the D2 antagonism. So that's what as I said, that I'm even among the first line with the propranolol, I'm worried about, the bradycardia. And with the this flunarizine, we are worried about extrapyramidal adverse effects. And we have seen patients coming with the flunarizine-induced extrapyramidal adverse effects.
Absolutely.
So
I have seen.
Yes. So one has to be wary about that, because it causes D2 antagonism.
Yes. Absolutely. Even flunarizine also can cause a slowing. Flunarizine people come with slowing. Yes. There was one patient who had migraine and migraine-related falls, and then falls disappeared with flunarizine, but he started becoming very slow. So we had to withdraw. Okay.
Yes.
So one more concept, new concept. Okay, there are some questions. I think Dr. Sriharsha is asking a question on magnesium, and with this thing will come. There is a slide on magnesium, so we'll come to that question when we use this thing. Okay. Why use 2 drugs leading to sedation? My take on amitriptyline and flunarizine. Oh yeah. Okay. I think Dr. Bijla, both of them are depressants, so that is why he's telling why use them together. Okay.
Yeah, maybe in a way is right that both of them can cause some sedation. But suppose if the person is already now comfortable on amitriptyline, using it for a month or so, not anymore getting sedated with it, then if we want to use, we can give. But of course, starting both together is not recommended.
Starting both together,
just as an add-on once the patient is already comfortable on one. Then.
To give additional benefit, or when it is not benefiting, or
yes. Yes.
The other thing is recently renin-angiotensin system modulating, because when it comes to anti-hypertensive related drugs being prophylactic for migraine, the thing that is very much understood was propranolol and metoprolol. But we never thought that lisinopril and candesartan can actually have an anti-migraine action. But the central renin-angiotensin system, okay, like when it comes to renin-angiotensin, we are only talking about in our physiology. When we were studying, we were talking about renin-angiotensin system as the lung and the kidney thing. Okay, I don't remember studying in physiology or in pathology about renin-angiotensin system modulating the brain activity. But then now it is with very, very well proper studies proven that there is a renin-angiotensin system in the brain. Okay, including having a pathogenic, having an action on Alzheimer's disease like symptoms, and also in conditions where pathfinding, spatial orientation, okay, and motor coordination, these kind of things also are worsened with the hyperactive renin-angiotensin system within the brain. And these studies are ongoing. And when it comes to lisinopril at 20 milligrams per day and candesartan at 15 milligrams daily, the modulation of vasoreactivity, alteration of sympathetic tone, and promotion of degradation of pro-inflammatory factors, all in the CNS. Modulation of endogenous opioid system and reduction of the angiotensin-mediated vasoconstriction. Increase of the sympathetic discharge, release of adrenal catecholamines, and modulation of modulation of central RAAS influencing neuronal renin-angiotensin system. Yeah. Okay. So that RAAS is a little difficult thing, because in neurology we also consider, I think, reticular activating system also as the RAAS. Okay. But here I think they are talking about renin-angiotensin system.
I think so.
Modulation of cerebral RAAS influencing neuronal, astrocytic, and endothelial cell activity. Okay. So if the person, generally what used to happen in the beginning, in the earlier days before knowing this concept, if somebody came for hypertension, they were taking a lisinopril, I would call up the physician and then encourage them to possibly, can you try to shift to a metoprolol, because this patient also has migraine. So maybe giving a metoprolol, shifting to will take care of both the hypertension and also the migraine. Whereas this is a revealing study which tells that, okay, no, it is even lisinopril is active. Okay, ma'am, your comments. Have you tried lisinopril anytime or seen any person with lisinopril actually reporting a reduction in their migraine?
No, sir, I haven't used lisinopril or candesartan. Somehow, even for hypertension, these are we usually use the angiotensin receptor blockers like telmisartan or sometimes ramipril. Nowadays, usually telmisartan or its other derivatives. Lisinopril is somehow very commonly used in Western world. I have seen like my cousins in US, whenever they have hypertension, they get prescribed lisinopril, whereas in India we usually use telmisartan as as the back of hand drug. So I haven't used lisinopril in migraine, though whenever we have international conferences, we hear a lot about lisinopril as an anti-migraine, but no personal experience.
So it is you have come across people using it as an anti-migraine agent also.
Yes, yes, certainly. So in international conferences, we hear people promoting lisinopril who are using lisinopril as an anti-migraine drug, especially if the person also is a hypertensive, so and say also is a diabetic, then it makes sense to use a renin-angiotensin system modulating compound. So you are tackling hypertension, you are tackling diabetic retinopathy, and you are also tackling migraine. So one drug, three effects. Yes.
Yes, ma'am. And ma'am, when it comes to there is one question: flunarizine and dosileucine. Have you used that combination?
I haven't used the combination, but I have used dosileucine as a migraine prophylaxis agent in people who are also, who are depressed, who have some, not exactly depressed, but who have some element of dysthymia, a little bit of sadness kind of a thing. There, I have used dosileucine. Dosileucine people, they come in, they keep on promoting that it is better than amitriptyline. Amitriptyline still remains my favorite because I have used it for so many years now. But of late, I have started using docilipine also as the less for migraine, more for tension type headaches. The other variety of primary headaches. There, I have started to use it. I haven't used docilipine with flunarizine. No, I haven't used docilipine with flunarizine.
Okay, ma'am. I think Dr. Pradeep Undavali has a personal experience of using that as a combination. I'm not sure whether.
Okay.
Okay. Okay. Dr. Neha is asking a question about.
What was his experience?
Dr. Pradeep Undavali, sir, you are there?
Hello, sir.
Hello, sir. Have you used flunarizine and docilipine as a combination?
Sir, I have been using this thing since past 5 years.
Okay.
4 years. Since 4 years, and in every our conference and workshop, I have been telling this thing because there are some overlap symptoms of migraine as well as tension headache in few patients. Overlap symptoms. And like particularly for the patients who come with vestibular migraine, for every patient, just the combination what I go is civilium with flunarizine with docilipine, 25 milligrams docilipine. Yes, sir.
Excellent. Okay, thank you. Thank you for that contribution, sir. Okay.
Thank you, sir.
Dr. Neha has a question on approach to a patient. Ma'am, this particular discussion is more of drug therapy. We'll have one more session on approach. On that day, we'll discuss approach in detail.
Sir, can I take a break for 2 minutes? I'm getting a call from emergency. Just 2 minutes, I'll be back. Sir.
Yeah, absolutely.
I'm just putting on mute. I'll be here only.
Yes, ma'am. We'll wait for you. Okay, I encourage all of you to please ask your questions, put them. Dr. Yona, I see you. Please. Okay. Hello, ma'am. Dr. Yana Voda. Dr. Sona.
Hello, sir. I don't know if it. Hello.
Yes, ma'am. We are able to hear. We are hearing you.
Okay. I'm so sorry. I am in the car in the middle of the mountain, but I cannot miss your webinar. So I wanted to ask this very nice lady and very smart. If now I started to try to check the histamine at our patient, and I found a lot of patients with chronic latent celiac disease, and if she has some special prophylactic drugs. I'm so happy to see you. Unfortunately, I have a very bad internet. It's from my phone. So
yeah,
excuse me. I don't know if you see me.
Yeah, I will ask that question. Okay, I'll ask. Maybe you can also
thank you so much.
type, if possible. Okay, I think you are driving, so I will ask the question. If you are not driving, maybe you could have typed that question, but that is okay.
Okay, I already tried. Okay, thank you.
Yeah, okay, sure. I'll ask the question. Okay. You drive safely. Okay.
Thank you.
Yes, ma'am. Thank you. Okay, madam is back. Okay.
I'm back, sir. I'm sorry. Yes.
Yes, ma'am. Okay. So
where are we? Nutraceuticals.
This is turning out to be a long session. Maybe everybody wants to break, but then we will continue. No problem. Okay, ma'am. So there are more questions. For you. Okay. So I will come to. We'll just go through the slides and then I will take up the questions. Okay.
Sure.
Okay. Because we have a huge agenda there. Okay. Then coming to. Or after this, nutraceuticals. Okay, so this will again take the Sierra question also. Ma'am, riboflavin. I keep hearing riboflavin is a good anti-migraine. In fact, I come across in literature where riboflavin's action as an anti-migraine agent seems to match propranolol. So, what is your take on riboflavin?
So if the patient is pregnant, then that is where we want to use the riboflavin as because we don't have other options. Otherwise, to use it as a standalone drug, either we use when the patient is pregnant and we cannot use other drugs because it is very safe, or we use it as an add-on drug along with some other standard migraine drug. Like suppose if I'm using amitriptyline and along with that as an add-on, I would give a combination of riboflavin, magnesium, and coenzyme Q10. So I myself have used this combination for my migraine, and I think it is good. It is good, but I haven't used it as a standalone only drug. No, I haven't used it as a standalone. Yes.
The drug that you use for your migraine is riboflavin, coenzyme Q10, and magnesium.
And magnesium. One pharmaceutical person came and gave me samples. I thought no harm in trying this. They're completely safe. And
these three are with no other anti-migraine agent.
With no other anti-migraine agent. So that combination is from Intas Pharmaceuticals. The name is Magrium. So it is magnesium, riboflavin, and coenzyme Q10. A combination of these three. So we use it as sometimes in pregnancy we use it, and if the patient does not want to take, if the patient is very particular that I don't want to take any agent, means I want to start with the most safest agent or very simple kind of migraine, there we may start, we may give this along with a strict advice on lifestyle, for intelligent patients, for doctor patients who don't want to take anything like me. So there we use it as a standalone, otherwise as an add-on.
Yes.
Otherwise as add-on.
Yes, ma'am.
So with amitriptyline, I'll add one Magrium. Yes.
Yes, ma'am. I think that will answer Sriharsha's question also, where you are talking about flunarizine and magnesium. Can we use them together?
Yes, we can. Certainly, yes.
Calcium channel blocker with magnesium. Yeah. I think Sriharsha, that was your question. You typed it as magnesium channel blocker, I think, but you meant magnesium with calcium channel blocker. Okay.
It may cause a little bit of constipation and all, but it can be used.
Yeah. Yes.
Theoretically, there might be a concern about constipation and slowing of gastric motility, but practically it can be used. Yes.
Sure, ma'am. So, and then there are some other medicines that are then Butterbur, Feverfew. These are all available.
Not used, sir. Not. I don't think they're available here. I haven't used.
Yeah. Okay. Yeah. We don't get them in the pharmacies. We don't get them on a prescription. But then there are a lot of alternative medicines that are available on this thing. If you just Google them, there are iHerb, so many things are there. Okay, things like life vitamins, different companies are there, which make it available. So we really don't know like the dose that they claim they have or they don't have. But then not on the prescription, but then they are available outside of the prescription. Okay. Magnesium causes diarrhea in many patients. That is true.
Okay,
there are a lot of patients.
I have to check it. I'm not aware. I haven't seen any patient coming back to me with the.
There
might be. Yes, I am not aware of.
There are some. Yeah. And amitriptyline causes constipation. Magnesium causes diarrhea.
Yes.
So maybe the two of them.
Yes, maybe two of them can be used together. Yes.
Yeah, can be used. Okay. Then one more question: role of melatonin. Ma'am, how frequently have you found the melatonin to be the one drug which has been effective?
In migraine, I think melatonin, I do use melatonin quite often.
Okay.
Not exactly as an anti-migraine drug, though now that I'm talking, I'm thinking that in how many migraine patients have I used melatonin? So I usually use it as for insomnia. And even for post-COVID syndrome, I have used melatonin, like post-COVID small fiber neuropathy, post-COVID dysautonomia. There I have used melatonin with acceptable effect, I would say.
With acceptable. Okay.
Yeah,
this question comes
effect.
from Dr. Yes.
But in migraine, I must have used in many migraine patients without realizing that it might help their migraine also.
Yeah.
Yes, I might have used.
This question is coming from Dr. Pratik Porwal, who uses it regularly, and then a lot of vestibular migraine patients are really benefiting with melatonin.
Yeah, I think yes, sir. It is quite possible if we think about the whole. It might be one drug that might be helping vestibular symptoms more than the headache symptom.
Yeah.
Melatonin.
Okay.
It is plausible to think of it that way, I think.
Yes. You have one more question, Dr. Iona. She's driving in the hills. So when you had taken a break, she had asked a question. this excessive histamine and celiac disease, okay, if they are having symptoms, what is going to be your approach, especially in celiac disease?
So in celiac disease, in like gluten, hypersensitivity.
Yeah, gluten.
For
Yes.
if gluten hypersensitivity people have migraine,
If I
what would
understood
I
the
use?
question right,
What would I use? I would use amitriptyline.
Okay.
Amitriptyline, it's fine enough.
Maybe there
it
is
does not,
even more detail in the question. Okay, her internet also was not
none of these
So
drugs
what I
has
will ask
gluten.
you,
None of
I
these
will
drugs has
connect
gluten,
up-
so we can give.
Okay, what I will do is I will connect the two of you after this. Okay, I will
Right,
share
sir.
her number
Sure.
to you, your number to her. So that question can be more clarified. Okay, ma'am?
Yes, sir.
Okay. Vestibular migraine suffer from TMJ arthritis, BERD, and hypothyroidism. Is it possible, Dr. Anju?
What is the
TMJ
question?
arthritis. Some vestibular patients also suffer from temporomandibular joint arthritis and gastroesophageal reflux disease and hypothyroidism. Okay.
Right.
Maybe it is,
Yes.
So have you
Some of the
had this kind of
vestibular
patient?
migraine, I'm reading it. So some of the vestibular migraine patients suffer from TMJ, arthritis, and GERD and hypothyroidism. See, many diseases can coexist in many patients.
Not as
Specifically,
But
this
one
combination, I can't not clicking to me whether I have used any particular Ramban kind of a treatment. GERD, yes, many patients suffer from GERD. That's very true. So we give PPIs. Sometimes they don't. Anyway, like they have nausea and other symptoms. So it's simply a like pantoprazole with domperidone that we add as along with. Anyway, we are also giving NSAIDs as abortive agents. So usually we would add one pentocid DSR, pantoprazole with domperidone to most of these patients. For temporomandibular joint arthritis, clicking to me what exactly would I do special for them? And for
Dr.
hypothyroidism, we'll give thyroid replacement. And we would avoid giving valproate to these patients because it can really cause weight gain, which is not, we don't want a hypothyroid patient to gain more weight. Already has thyroid hypothyroidism to give him weight gain.
Okay. That is what one thing is, like a lot of people who think that they have GERD actually have migraine.
Yes, true. A lot of people who think, yes, and people actually have GERD. People actually have migraine for which they take NSAIDs, then NSAIDs give them GERD, and then that GERD precipitates their migraine, and then they again take NSAIDs, so it becomes a vicious loop. So many times people are admitted under gastroenterologist and we are called for headache, and all that we do is that we ask them not to take NSAIDs, and we add one migraine prophylaxis, and we explain to them that the actual disease is migraine and not GERD. Yes.
Absolutely.
Yes.
Dr. Neha, I think your question relates to evaluation. Drug related, please do write the question again so that I will put the question to madam. Evaluation, we'll have one more session. Okay, most of what is happening today is drug related. Then non-pharmacological approaches for migraine. When I talk about non-pharmacological approaches, we are not talking about here the lifestyle, and which is very important. There are some things that are coming up now. Okay, there are there are some questions, things that are coming up, non-pharmacological approaches for migraine, like anodal transcranial direct current stimulation. Okay, I'm just mentioning for so that this is whoever has come here, joined here this evening, also knows what else is happening out there. Then there is a single pulse transcranial magnetic stimulation. This one thing of all the things is also being studied for acute treatment, whereas other things are like the transcutaneous supraorbital stimulation and transcutaneous vagal nerve stimulation. All these things are meant for prophylactic. There is one thing, magnetic single pulse transcranial magnetic stimulation, which is supposed to be for acute treatment. So let us see what exactly how these things turn out to be. Ma'am, have you come across anybody doing any of these things, or as a trial or as a therapy?
So when I was so way back in 2012, when I was a third year DM resident, at that time I did my DM from Jipmer Pondicherry, but I had a 15 days posting in they have a tie-up the institutes. So I had a 15 days posting in Sri Chitra Institute in Trivandrum,
Yes.
and 15 days in Nimhans in Bangalore for neuropathology and for epilepsy respectively.
Okay.
So there in Sri Chitra, I had seen single pulse. I had seen a TMS machine being used in a research setting for migraine preventive and abortive treatment. The machine was not like this handheld machine which is shown here, which must be a portable kind. That was a huge machine, and it was being used as a research purpose for migraine. That is where I have seen the transcranial MS. We have one in AIMS also in Delhi, but it is not otherwise available in private institutes or routinely available for therapy.
Sure. So that one is okay. The last one, of the thing that is actually making waves, and at least the initial reports as of now, which I get from my friends, my neurology friends so far, is effective. Especially Dr. Vishal Pawar tells that he's found this to be useful. Okay, in fact, there are some papers also which have started coming in vestibular migraine also. In migraine, they have been used, but in vestibular migraine also, there are papers which have just started emerging of calcitonin gene-related prophylaxis related related benefit. Okay. So basically, CGRP was described 35 years ago in rats as a potent endogenous vasodilator. In the peripheral nervous system, it is located in unmyelinated C fiber and small myelinated A delta fiber, both responsible for pain transmission. Centrally, it is well distributed throughout several structures, including the hypothalamus, thalamus, and cerebellum. Based on several lines of evidence, which suggests CGRP as an important molecule in the pathogenesis of migraine, this neuropeptide and its receptors have become attractive targets for the development of migraine treatment strategies. CGRP exists in two isoforms, both alpha and beta. Alpha CGRP results from alternate splicing of mRNA and proteolytic processing of calcitonin gene. It consists of 37 amino acids, particularly present in the trigeminal system, where half of the neurons in the trigeminal system actually synthesize this. And beta CGRP is transcribed from a different gene and expressed primarily in the enteric nervous system. Maybe that's the gut and the brain. Okay, in two different places. The common connect could be the CGRP. Okay. Then there are GPANT. Okay, there are a lot of drugs called GPANT, Ubro GPANT, Eto GPANT, Remi GPANT, and all these things. The first successful attempt to antagonize the CGRP mechanism in acute migraine therapy was performed with intravenously administered BIBM 4096DS. Several trials with small molecule CGRP receptor antagonists in oral formulation also demonstrated that targeting this pathway is an effective way for treating acute migraine. However, their development was complicated by signs of hepatotoxicity and pharmacokinetic issues. But new small molecules such as Ubro-GPANT, Eto-GPANT, Remi-GPANT are currently investigated in clinical trials for acute and preventive migraine therapy. However, attention has recently shifted to the development of monoclonal antibodies, away from these GPANTs to monoclonal antibodies, targeting the CGRP pathway for the prophylactic treatment of migraine. When it comes to monoclonal antibodies, okay, in 1982, the first report from a patient with B-cell lymphoma demonstrated that monoclonal antibodies have a therapeutic activity. In migraine prevention, monoclonal antibodies have several benefits compared with the small molecule receptor antagonists. What are those advantages? They have a longer duration of action that allows for less frequent dosing, sometimes once in a month, sometimes once in 2 months. Also. Antibodies are highly specific and can provide more effective blockade because it is specific to that particular CGRP or its receptor. Antibodies are mostly eliminated by proteolytic dehydration and not involving the liver and not substrate for P450 cytochrome isoenzyme. Therefore, the potential for hepatotoxicity and drug-drug interaction is massively reduced. Because of their large dimensions, low permeability through cell membrane, instability in the gastrointestinal tract as they are proteins, monoclonal antibodies must be administered only as an injection parenterally. They do not penetrate into the brain unless the blood-brain barrier is wide open and respectively destroyed, as in stroke or meningitis. So the effectiveness of monoclonal antibodies, which do not really enter the blood-brain barrier, still effective, tells that there is a peripheral mechanism which is actually causing a central disease. So much here about monoclonal antibodies. So with that, okay, and then there is ma'am, When it comes to G-PANs, have you tried G-PANs for migraine?
No, I have tried. I am now these days increasingly using monoclonal. The only monoclonal antibody that is available in India is Erinumab. Is this
Erinumab,
available?
okay, ma'am.
Yes, Erinumab.
How much is the cost?
No, so 19,000 per injection of 70 milligram. 19,000 per month.
Per month, 19,000 single shot
19.
injection.
Yes,
What
yes,
has
one
been your
shot.
experience? What has been your experience?
My experience is positive, I would say. I have used in 5 patients so far, out of which 3 patients had good response. 2 patients didn't have good response with 70. I asked them to go to 140, but then they couldn't afford to go to 140 because that would increase the around 40,000. It's 38,000 per month. That becomes too much. But 3 of 5 patients, I have used only in 5, very small number. But 3 of 5 patients, good response. I have been able to stop all other migraine prophylactic drugs. So these were the patients who
How
had
you
gone
are
up
giving
to,
it?
sir.
Finish, ma'am. After that, I will call.
Yeah, so like these were the patients who were, not getting controlled despite taking repeated short steroid courses for medication overuse headache, and they were on 3 to 4 migraine prophylactic agents, including the first line, second line. So patient who is on valproate as well as on beta blocker as well as on flunarizine. So he's also having adverse effects, but is not getting relief from headache. These patients I have used chronic migraine patients who have more than 15 days of disability, of more than 15 days of active syndrome, which can, in case of cephalalgic migraine, it would be headache. In case of vestibular migraine, it will be other symptoms, the vestibular symptoms. So more than 15 days, almost disabled patients not getting controlled on 3 to 4 drugs. There I have used, and in 3 out of the 5 patients, after I initially started as an add-on, I didn't stop their migraine drugs. After 1 month, I reduced 1. After next month, I reduced a second. By the end of 4 to 5 months, I was able to keep them only on the monoclonal antibody, which is a big thing actually for such patients.
Absolutely.
Difficult to treat migraine. Yes, sir. Yes.
Yes, ma'am.
Difficult to treat migraine, not controlled on polytherapy. There. And their 19,000 per month is not at all, it doesn't pinch the patient because he's already using so much and so many drugs and eating them daily. So this is one shot a month. Such patients are willing to take it.
And it works both for migraine and vestibular migraine.
It should, sir. We don't, like all other migraine drugs, this should also work for both. Because ultimately it is only that one is involving the trigeminal pathway more and one is going through the vestibular mode, but they are the same disease.
I spoke with one patient with vestibular migraine and she was super happy. She told that.
Right.
Yes, ma'am. Yes.
And very safe, sir.
Yes, ma'am. Okay. Ma'am, Dr. Neha is asking a question. What is the key points to be kept in mind, before prescribing, especially I think she's talking about an elderly patient.
Before prescribing CGRP, this monoclonal antibody inhibitors.
No, the overall medicine, overall anti-migraine medicine. I think it's a general approach. What do you think before you,
there is not one key point. The key point I would say is, one, whether this patient actually needs a prophylaxis. If we don't give prophylaxis to all migraine patients, if the episodes are, I'm talking of migraine with headache, if patient is having 1 or 2 episodes in 1 to 2 months, then abortive therapy with lifestyle medications, SOS abortive therapy with lifestyle medication is enough. We start using prophylaxis only if the headaches or vestibular symptoms are significantly disabling to warrant a prophylaxis. We try to give the patient the safest drug which suits the patient profile. So suits the patient profile means that whether the patient has any other comorbidity also, and we keep the comorbidities in mind. So if a patient is having bronchial asthma, then propranolol does not suit his profile. If the patient is having liver dysfunction, then valproate does not suit his profile. So like that, if the patient is a very high functioning individual, then I would think twice before starting topiramate, though it doesn't cause cognitive dysfunction in all, but I would not want to take a chance with such a patient, such a person. So like that, what is the overall profile of the patient? What are the comorbidities of the patient? What job does the patient hold? What are the demands and responsibilities of patient? As per that, which is the drug which would be most suitable for this patient? that is the one I choose. And then
Yes, ma'am.
the next step is to follow both for efficacy as well as for safety. So whether the drug that I gave was effective in this patient and whether it is safe for this patient and whether it is causing any untoward adverse effects. And if it is causing, then I have to pick them up in time and like I have to correct it. And then simultaneously to focus on the non-pharmacological lifestyle oriented education. So simultaneously to focus on that and to educate the patient about the disease, about migraine as a disease. It is very important. A migraine patient can handle himself or herself only if he understands his disease. Otherwise, there is a common myth in the society. Whenever we say you have migraine, patients say, Doctor, migraine ka to koi treatment hi nahi hai, ye to kabhi theek hi nahi hota. So like, and then we tell that if you know your disease, understand that you just need education. It is not such a difficult disease. So these are the things. This is the general approach, how to approach a migraine patient, whether vestibular or whether see, when I say headache or vestibular, these are not mutually exclusive. Most of my headache patients do have vestibular symptoms also. Although vestibular migraine per se, which has primarily vestibular symptoms and less or no headache, it doesn't commonly come to me. But most of my headache predominant migraine patients, when I ask them, they do have vestibular symptoms also. So it is not a mutually exclusive thing.
Yes, ma'am. Okay, that's a very important point that as a neurologist, you are telling most of your headache patients also have vestibular symptoms. So they are really not mutually.
When we seek it, it comes. Yes. So patient will say that when I'm walking, suddenly for a second, I feel that there is a spatial disorientation. For a second, I feel that, as if there is an earthquake, and then no one else feels it. And then I'm all fine. Or patient will say that when I'm sitting in front of laptop, I start feeling that things are becoming dizzy. So this is very, when we seek it, we get it.
We get it, exactly.
And tinnitus also, sir. Tinnitus, many headaches start with tinnitus as an aura. Tinnitus is a very well recognized aura. Many patients get it when we ask about it.
Absolutely. Ma'am, one more question here. Okay, so I think most of the questions. Okay, do migraineurs have persistently elevated CGRP or CGRP elevation corresponds to migraine episodes? I'm not sure whether this is there.
Chronic migraine, CGRP is in chronic migraine we define as more than 15 migraine days in a month. So in chronic migraine, CGRP is persistently elevated as per studies. In episodic migraine, it might be, I will have to go through the literature. I'm sure about chronic migraine that it is persistently elevated. I think in episodic migraine, it might be episodically having its peaks and then falls. And the baseline also might be a little bit more elevated than the usual person's, non-migraineurs baseline. Adalimumab initially was launched only for chronic migraine. Now it is, I heard that it is getting licensed for episodic migraine also.
Wonderful, man. And it maybe that is the holy grail in migraine that we were looking for. If it starts making change, then maybe it will start becoming available at a lesser cost.
Yes, already there are companies which are now in India, like, who are coming to us saying that we will be launching it soon at a much lesser cost. So what is the scope for it? If it comes at a much lesser cost, then there is a huge scope for it.
There is a huge scope. There is a huge scope. Definitely, there is going to be a huge scope because it's such a disabling disease, and most of us, in fact, a lot of doctors would take it.
Yes. Actually, out of my 5 patients, 2 are doctors.
Oh, okay. That is it. So you'll have even better.
Confidence.
Even better. And they will also tell exactly how they are feeling.
Feedback. Yes, truly.
Dr. Neha has one more question. In headache in an elderly, which is your go-to drug?
Amitriptyline.
But for the acute headache?
Oh, acute headache. For acute, like for headache, we use usually we use a combination of naproxen with domperidone, or we use a triptan, like rizatriptan, or increasingly, for some people, I use a combination of rizatriptan with like paracetamol 650. So just rizatriptan plus paracetamol 650, especially if there is dyspepsia and other things and GERD vicious loop.
Sure, ma'am. Yes. Great. Thank you. So Dr. Bijlani says a good discussion today. Congratulations to Dr. Sushma for a wonderful presentation of solving multiple queries we all have. Thank you. I understand that today's discussion is on drug therapy, but would like to emphasize the role of lifestyle corrections, which do go a long way in the patient's well-being. After all, it's a lifestyle disorder. Attacks are warning to make changes. Yeah, I know.
Yes,
Okay, and he himself is a migraine sufferer like me, like you, all of us. So when he says that it is a lifestyle, all of us have to agree. Dr.
True,
Yana Vada says congratulations. Dr. Neha says great discussion, and Dr. Anju, great learning. So Dr. Yana Vada, I will be sharing Dr. Sushma's number with you. We asked the question on celiac disease. Maybe more elaboration she will be doing on a one-to-one to you again. Okay, I'll share her number to you and your number to Madam. Okay.
So I also want to say that it was a great discussion, and it is always a mutual learning. It is a mutual learning thing, and I learned a lot of things too. Many things got freshened up also, especially the mechanism of action and other things which we tend to not focus on in day-to-day practice. So it is always a pleasure listening to you, sir. Always a pleasure. Like it's very inspiring. It's extremely inspiring to listen. The kind of details that you go to, extremely inspiring.
Thank you, ma'am, and thank you for joining, ma'am. Thank you, and
thank you, sir.
Let us keep this going every Friday.
Certainly,
last
sir.
Friday of every month. This will continue, God willing. Okay, so 8:30. Keep that marked in your calendar. So all of us will keep meeting. This is a good fact. We are developing a family here. All of us. Okay, we have started recognizing one another by your name. We start seeing who are all here. So that is wonderful. And if you have cases to be presented, only this time we took an offshoot, like to only keep it for drug therapy without a case. But again, from next month onwards, again, it is going to be case-based discussion.
Sure. So
thank you all. Thank you for all the good wishes. I can see Ravi Kishore saying thank you, Dr. Anju, Dr. Priyana, Dr. Krupa, Dr. Neha, Dr. Sonali. Thank you all. Like I also see a thumbs up. Okay, Dr. Mamta. Okay. So thank you all. Okay.
Thank you,
so
sir.
With that, thank you all for joining, and thank you, Sushma ma'am. You really enhanced the knowledge of a lot of people today. A lot of our doubts have been cleared, and a lot of clarity has come today. So we have overshot the time, but that is okay. I think we will be forgiven for that. Okay. So thanks all. Thank you all, Dr. Anju, Dr. Rajshekar, Neha, all of you. Thank you all. Thanks, Sushma ma'am. Thank you.
Thank you, sir. Thank you, sir.
Thank you, ma'am. Thank you, ma'am. Thank you. So with all your permission, yeah,
Sure,
I'll end the meeting.